Hello, good to see you all again. I'm Sang-Cheol Lim. I hope you are all having a great summer. So today, as usual, the live surgery will be performed by Dr. Chung. He will be doing a simple implantation using the bright tissue level implant system. And we'll go over what factors to consider during this procedure. Okay, now we will proceed to today's case. Today's case actually simple implantation on short lead using bright tissue level implant. As you can see, about the patient information as follows. 77 years old female patient, she won't get the implant surgery to have a new teeth. About the past dental history, missing of many teeth, actually multiple extraction when we visit the last clinic. And past medical history, non-specific here. As you can see, after extraction situation on panoramic view, actually 2 months ago, June 22nd, just remaining number 15 and number 21 in upper right quadrant, and lower maybe the layer, the nature teeth are remnant here. What about the CT scan? About the 13 area, actually normal situation is not so bad. About number 14, also the similar, it's okay. And number 16, also the wide reach and the height. So it is not so bad. But however, number 21, the anterior teeth area, actually no labial bone plate. So this situation is very difficult to get the good aesthetic outcome. So we need more gentle and the delicate surgery for this aesthetic situation, aesthetic area. About number 44, very little bit sharp ridge, but we can do the implantation. Number 46 area, also little bit sharp, but we can do the implantation, just a small bone grafting. This one is intraoral scanning, looks like here. So take a photo, intraoral photo. So we took this intraoral situation, recorded for in future the processes procedure. Virtual setting up here. So we align and plan the proper and best implantation position before the surgery. So virtual setting up is very important procedure when you have a top-down style implant surgery. Okay, so after this virtual, we can get the digital guide, the stent, or something else, another information. What about the intraoral view? As I mentioned before, the multiple missing teeth on upper right quadrant area. So just only one tooth remnant, number 15. What about the lower? Lower is very similar. Just only one, number 43, the canine is remained, and the already installed implant fixtures stay there. So we're going to have a surgery plan as follow. Extraction of number 15, this tooth is not a benefit to have any advantages for in future processes. And bone graft for socket preservation using osteon geno, osteon 3 collagen, and collagen graft 2. And implantation on number 13, 14, 16, and number 21. Number 21 area is immediate implantation situation. So we can see this aesthetic areas immediate implantation using the bright tissue level. and lower jaw, implantation on number 44 and number 46. So even though the narrow reach, but we can overcome using the bright tissue level, looks like here. So just the minimum, the bone grafting are necessary when we use this bright tissue level picture. So just brief introduce about the osteogeno. This graft material is brand new from Dentium company, natural bovine grafting materials with osteoconductivities and the wettability, higher wettability, and the interconnected porous structures are high and similar to human bones. So we can expect this xenograft performance getting better than before, than the alloplastic material. About the collagen membrane too, this one is upgrade version. These membranes have a new, the brand new product from Dentium company also. This membrane, the barrier membranes have a fast wetting and easier manipulation and pin friendly, the tear resistant characteristic. It means we can apply this membrane like a sausage technique or burrito technique, like we can use a more versatile situation. Long-term stability over 6 months is the same as before a previous version, and multi-layer microstructure. Comprehensive understanding for today's surgery. Let me introduce about the similar case one. This one is a simple implantation using NTI. NTI means a bright tissue level implant fixture system. So just a small incision are necessary, and just a simple drill and installations. That's it. So very simple and quick procedures are necessary to implantation. So this one is most advantageous factor when we choose and when you use this bright implant system, even though the bone level and the tissue level doesn't matter. And this one is after installation panoramic view. As you can see, a very nice, well done implantation looks like here. Actually, this tissue level implant have a same only one platform, 3.8 millimeter diameter. So simple prosthetic procedures are as follows, and zirconia, supported zirconia superstructures to connect with NTI implant fixture. So final restorations and was done and taken the panoramic view. Okay, so this one is intraoral view after insertion of superstructure, the zirconia final prosthesis. And this one is another case, actually multiple edentulous areas overcoming and supported the NTI implant fixtures, superstructures. As you can see, multiple GBR procedures, and we can see the pin and screws and sinus elevation situation, and also the NTI tissue level implant fixtures already done, upper right molar area, and also the bone level implant inserted anterior and upper left area. So we can use bone level and tissue level implant fixtures just using one system, one drill kit. This one is a unique of the bright implant system. So as you can see, small incision and the drill and the insertion. And that's it. Especially these tissue level implant fixtures are very simple and stronger than the same size bone level implant fixture. This one is actually 3.8, but can support all these premolar area, even though we can use this 3.8 diameter on the molar area, right? So simple bone grafting and all the implant fixtures already done very nice with a big GBL procedure. And final lacerations looks like here. This one is actually provisional, and the final lacration, a panoramic view. So even though the small diameter, the body, but platform is a 3.8, so emergency profile is getting better than the small diameter, small platform system. So this one is a superior advantages compared to any other implant systems, tissue level. So final process looks like here. Okay, so today's surgery is starting. So Dr. Chung is adapting the already prepared milled digital stent, the milling stent here. Okay, so he is starting the surgery, today's surgery. Number 21 area, he will extract this number 21 at the front tooth using the forceps. The poor period conditions, so extraction procedures are so easy. But after extraction, we have to check in the socket, right? Depend on the socket, the situation, socket status, we can decide a different type of implant step. It means intact socket, immediate implantation, right? But unfortunately, absence of labial bone plate or small penetrations or small dehiscence site, we can do also immediate implantation. But the big defect case, maybe we have to consider delayed approach, right? So he extract number 21 tooth and adapt again with a milled digital guided surgery stent, and using the pilot drill, actually Lindemann drill, checking the proper position, exactly, just a small indentations. Okay. He didn't go full depth drilling. Just he want to take the position, so just shallow indentations are made. After that, this one is actually Lindemann drill. It is not guided drill, but anyway, he want to have a Lindemann drill here for checking position. Okay, so after extraction number 21 and number 15, and okay, so he is not going to use digital guide anymore now. Semi-digital type actually. Dr. Chung preferred to use this digital guide stent for the positioning, and then after that he want have a manual type, a freehand style surgery, cause of the past almost 30 years. He got experience, lots of experience about drilling, depend on different situation and bone qualities and areas. So he preferred freehand style surgery. I think Dr. Chung trust his hand than a digital guide from the computer. So, okay. After extraction, make entry point and the guide drill, guide pin here. So he is gonna see the underneath bone profile. So make an incision and flap reflections will be prepared. He wants prep reflection. He want to see the bone profile before starting the implant installation. So now he is using the periosteal elevator, flap reflection. The number 16 area have some depression. Number 15 areas, socket, the prominent socket, especially the buccal portion is prominent. And flap reflection here. So, he is gonna see the full bone texture. Actually, this bone so soft, looks so soft, right? So, in this situation, we have to consider undersized drill for better initial stability, right? This area is number 14. Oh, the patient have coughing. So she need a little bit more relax. Okay, this elder person, age 77. So we have to consider this age, right? So the simple and minimized surgery concept is the best option for the elder senior person. Checking again the pass. Okay, move neighbor. Move next door. It's actually number 13 area here. Here is moving number 13. Make initial drill. The osteotomy site, checking the osteotomy site. Number 21, anterior central incisor area. When you have immediate implantation, especially anterior socket, we have to consider many factors to getting the better and best aesthetic outcome. First, the actually entry point. Entry point is very important. So we have to make entry point, the palatal slope, the palatal socket work from the gingival margin around the 7 millimeter deep into the socket. So make indentation, the palatal socket work, and using these indentation areas, very gentle up and down and up and down. The drill sequence are necessary part. Cause of this slope is easy to slip, slippery area, cause of the cortical layer. Okay, 3 osteotomy site determined, decided, number 21, number 13, and number 14. Okay. So number 16 area, using osteotome, the crestal approach, little bit elevate sinus floor. So crestal approach, the malleting, use osteotome technique. Okay. Okay, very interesting questions are here from Guangzhou from China. Doctor asked me, when after using bright implant, don't you use a lot of supine implants or choose 2 implants according to the situation in Korea? Yeah, both of implant are used actually after using bright implant system. Cause of supine have a fully tapered shape. Gross anatomy have a fully tapered situation. So softer bone, especially posterior maxillary area, supine have better performance when we choose supine implants, right? Bright implants have another advantages, like the hard bone, like lower mandible type 2 hard bone, is bright implant is better than supine. Cause of bright implant system looks like straight style, and supine have a fully taper. So according to this gross anatomy of implant fixture shape, so we can choose depending on the bone situation, bone qualities and bone quantities. And also depending on the surgeon's technique, right? So we can also use both of them. Thank you, Guangzhou. So as you can see, it's just small drill steps are done, and directly implant fixture insertion. These fixtures diameter 3.5, 9 millimeter, length 9 millimeter, diameter 3.5. Actually 3.5 is very narrow, especially number 13 and 14 area. But this 3.5 NTI is almost the same stronger as number 4.0. 4.0 diameter, the bone level implant fixture. It means even though the smaller diameter, but getting stronger, getting better performance compared to a bone level implant. So Dr. Chung choose finally tissue level 3.5 diameter, but platform 3.8, right? It's very important thing, important factor. 3.8 means the same as 4.0 diameter supine fixture, right? And number 16 area, Dr. Chung insert 4.5 diameter, 4.5 and 9 millimeter NTI bright tissue level implant fixtures already done. Okay, so Dr. Chung is socket filling here. I guess this socket almost intact, right? So Dr. Chung just put the simple grafting instead of any membrane, any other the complex complicated procedure. Just put the graft in the side, in the socket. This graft material is osteon xenograft from bovine. So xenograft particulated bone inserted into the socket. As I mentioned before, anterior implantation, the position is very important, right? Now insert with 3.5, the same size diameter, 9 millimeter, platform 3.8. Already done here. So very interesting. The ordinary gap filling followed implant insertion, right? The implant insertion first and the bone grafting materials for gap filling. However, Dr. Chung drill and bone grafting and insertion. The interesting procedure. Which one is better? Actually, I think sometimes these kind of procedures are better. What kind? Actually, big defect and some the behind and hidden big defect case. Actually, after insertion, these areas it is very difficult to fill with the bone graft material. So in this case, the bone grafting first and insertion is better. Normal case, actually, implant fixture insertion first and gap filling is a regular procedure, right? Okay, just bone grafting materials in the socket. As you can see, it means this socket was almost intact, right? If labial bone plate missing or some penetration or dehiscence defected there, maybe we have to use a barrier membrane with graft material. So healing cap here. This healing cap working as the scanning jig for intraoral scan. It means the name scan comfort cap, right? The official name is scan comfort cap. Scan comfort cap, dual function. First, the scanning jig, working as a scanning jig, and another one as healing abutment, right? So all the implants already done, the 4 implant installed with the healing cap, and the extraction socket, number 15 areas filled with the osteon-3 collagen. These collagenized bone have many advantages, like this socket area. Nowadays, bone grafting materials with the collagen enhanced, like this osteon-3 collagenized graft materials, nowadays prevailed in the world, actually, cause of easy handle and holding the graft materials. So sometimes have some barrier effect cause of collagen binder. So yeah, this one is a collagen graft. Yeah, collagen graft have very nice tissue integration properties. So well integrated soft tissue. So even though the open style, the open healing technique, open styles, flap management, doesn't matter. Faster soft tissue heal, we can see the faster soft tissue healing. So what kind of advantages when we use these collagen graft? First, we skipped a vertical incision or the periosteal releasing incision for the primary closure. Right? So this collagen graft cover the exposed socket area, the underneath osteointric collagen, also holding the graft materials with collagen binder, and up top portion, the collagen graft, and both of materials the secure the extraction socket area, even though the open or not fully the intact closed the flap, it doesn't matter. So this one is very important, the checking point. We don't need a periosteal releasing incision anymore. It means the reduce the swelling after surgery. The patient, the discomfort is also the reduced. The patient comfort and the happy, the faster healing. They are best options for the elder, the senior person. So Dr. Chung moving to simple and easy implantation and the minimize surgery concept, especially treatment of his senior patient. Okay, so just only one the pin used for flap fixation, and now here is starting with suture, the modified horizontal mattress suture here. Another the modified horizontal sutures will be done around number 13 area. Now, actually, a very interesting another questions from Shanghai, China. Thank you, Shanghai. If collagen membrane and graft 2 comes out, will the existing product disappear? I don't think so, actually. The grafted materials, bone grafting, particulated bone, and collagen membranes combination also have a good performance. So depend on situation and surgery field state and surgeon's style. All these factors finally choose which one is better for my surgery. It means I'd like to use collagen membrane and particulated bone combination. I trust this combination. If you trust this combination, you can go this way, right? Still open and still useful and still very good advantages, particulated bone and collagen membrane. But another way, actually, osteointric collagen and the collagen membrane and collagen graft also apply to depend on the status of surgery field. It means simple bone graftings. You can apply osteointric collagen instead of the particulated bone, right? And some areas, like this socket gap filling area, you can use osteointric collagen also instead of osteogeno particulated bone. right? It depends on the concept. So there are many different concepts to going to the top of mountain. Actually, there are many ways here. So you can choose the best option for you, optimized for you, customized for you, right? So grafted materials, particulated bone, collagen membrane combination is very useful. Also, activation, working, very nice. Some person use the, yeah, the plasma membrane like this one, or some sticky bone. It doesn't matter. You can choose. You can use every one. However, Dr. Chung have a concept shifting to simple and easy and minimize, right? So achieving his concept, he want to have simple materials, applying simple drilling and install, and the small incision, then the minimized flap reflection, all the performance, the focusing on his concept, minimize surgery. So I'm not sure your concept, but sometimes this one is very useful concept for our elder person, a senior person, senior patient. Okay, 2 pins and additional sutures. All the surgery field closed here. I think just only 20 minutes, about 20 minutes. He have done 4 implant installation with socket preservation and simple GBR, and now finishing the suture, very faster. How can he achieve this surgery so faster? Here, first, the choosing the materials, and number 2, the simplify the drilling sequence, the implant system. Yeah, very well done, very nice performance upper the surgery field, actually. Finally, he want to have number 21, number 13 areas, one piece of final restoration, and number 14 and number 16 area, so another one segment for final restoration. Basically, 2 part, 2 segment for the restoration, restore this all the missing area. Okay, very well done. Oh, he moved to lower now. Okay, number 43, lower canine is a solitary tooth remaining there, and actually already done. Actually, already done means not today, not the same procedure. Actually, this implant may be previous installed before. I don't know how many years ago, but around number 45 area, the old implant fixtures are installed. Trying again with the build surgical stent. Checking the position. Good adaptation. We see good adaptation of this digital milling stent. Now he make indentation of pelvis surgery. Yeah. Okay. Without pelvic flexion, stent adaptation and make indentation with a pilot drill. I'm not sure he will the flap open or not, actually. The installed before area, number 45, implant fixture areas, soft tissues conditions bad, cause of keratinized tissues, lack of keratinized tissue. So he make an incision. Any keratinized tissues, keratinized tissues absent. We cannot see keratinized tissue around installed before area, number 45. So he make an incision, the crestal incision. Double checking the clear cut, the incision line using the periodontal curette. Okay, so now we can see clear this number 46 area. Okay, you want to grind out this cortical, the prominent area. This bone is useless actually. Low speed round bar, grind out the cortical, the prominent area, the flattening, the plait, flattening procedure. He is not going to able to fixture installation around this area, so he want to grind out this cortical, the prominent bone portion. Okay. Okay, connect with the healing cap. I'm not sure this implant system installed before. We have to check from the panoramic view after surgery. Okay. Using Fisher bar, high-speed Fisher bar, make an indentation for osteotomy. Okay. Now sometimes Dr. Chung is using a high-speed fissure bar to make an indentation for osteotomy, especially these the thick cortical bone area. Okay, so and change the bar. Yeah, this one is Lindemann with 1000 RPM with irrigation. Now, drilling sequence is very simple. As you know, Lindemann, final, install. That's it. Yeah. Lindemann until 9 millimeter. This bright system have an odd number, 7, 9, 11, like this one. Superline implanting system have an even number, 8, 10, 12. Okay, the pass pin have a unique shape. Can you see a little bit like the dish-like, the parallel pin? A dish means have the number. Can you see the 8 millimeter? 8 means 8 millimeter diameter. The dish is 8 millimeter. Dish means final lacewation diameter, right? So if you use this the paralleling pin, we can put the implant fixture, the center portion of a final lacewation, right? So we can manage the three-dimensional positioning. So this dish type parallel pin, the positioning pin is very useful, right? 8 millimeter, 7 millimeter, 6 millimeter, the various different diameters with the pole. So we can measure the mesiodistally, the buccolingually, and also the pass. And this one is 8 millimeter. 8 millimeter means the molar area. Premolar, maybe 6, 7, right? So first molar of lower first molar, 9 or 10 millimeter, right? Yeah. The crown size, mesiodistally. So he is installed the final implant tissue level, checking the pass and the installed the diameter at 3.5, the platform the 3.8, right? Can you remember? All the tissue level implant have one platform, 3.8, the same size platform, 3.8, right? Platform is same, but different diameter. Okay, so yeah, the posterior portion, number 46 area, 3.5 diameter, 9 millimeter, NTI tissue level implant. Very well done, installed. Remove the plastic cap and connect with the scan abutment, dual function, healing and scanning. Scan comfort cap is official name. Once again, scan comfort cap. Okay, so yeah. Another one advantages of this NTI tissue level implant is initial stability. Very easy to get higher insertion torque and initial stability, right? Even though the softer bone cause of a thread design. So we can connect with the healing cap very easily. Or using pin for fix the flap. Suture is starting. Keratinized zone is wider. Keratinized zone is widening due to the healing cap insertion. On number 45, installed before, the previous installed before the fixture, round areas. Suture, the simple interrupted suture here. Okay. For me, this pin actually, I prefer to use this pin fixation upper jaw because of bone hardness. Actually, lower jaw is too hard. Sometimes very difficult to fix of this pin. So lower jaw, just a suture. Upper jaw, the combination of pin and suture. So actually, for me, I prefer to use the finishing the flap procedure. Okay. I think this nut is almost final. So, today's key point of surgery, the proper positioning using digital guide, and how can we achieve insertion torque, initial stability, even though the socket area, right? And the proper positioning, immediate implantation. Can you see, can you remember number 21 area, extraction socket area? How can we achieve the insertion torque and initial stability, immediate implantation when you have immediate extraction site? Dr. Chung showing to us a very useful, valuable technique. Okay, the surgery was done, and yeah, I will be back in 10 minutes after break session. Thank you. Thank you very much. Welcome back. Thank you for waiting for us. Let's see the post-op panoramic view, number 13, 14, 16. We can see very nice, parallel, well done, installed NTI bright tissue level implant fixture. Number 14, number 13, 3.5 diameter, as I mentioned before. However, number 16 area, 4.5 diameter. But the platform is same, 3.8. So we can recognize all of this information from this panoramic view. And also number 21, socket, immediate socket implant installation areas. I think 11 millimeters are also available. But today, Dr. Chung have decided 9 millimeter length, 3.5 diameter. So anyway, this socket also good installed area. And what about number 44, 46 area? 3.5 diameter, 9 millimeter length, platform 3.8. Yeah, so I think these two implant fixtures available for final restorations. Okay, very well done and good, simple implantation surgery today. Thank you for Dr. Chung. I deeply appreciate Dr. Chung today's surgery. And let's move to one question. Actually, this question about the NTI system from Vietnam. Thank you, Vietnamese doctor. His question is that usually I'm a little worried about using a tissue level on the anterior. What are the advantages and precautions of tissue level installation at the anterior? Actually, I'm also worried about the tissue level in anterior because of the profile and aesthetic, right? So sometimes tissue level fixtures confusing us the depths, proper depths, right? So all the three-dimensional reference from the bone level implant, the standard bone level implant, top portion of bone level implant, the platform of bone level implant is the reference line for depths, right? It means from the CJ neighbor teeth, 3 or 4 millimeter deeper insertion is suggested, recommended, right? It means the bone level implant. This one is bone level implant. So bone level and tissue level is different reference line. So sometimes we can confusing the proper positioning. So yeah, that sometimes I'm also worried about the anterior. However, what the advantages? The precautions. Precautions are already, as I mentioned before, the depth of install is very important. The final emergency profile and final restoration, right? So what are the advantages? Let's see. The normal socket size, normal range width, the reduced edge, the remnant of the edge. Actually, first of choice, bone level fixture, right? However, narrowed, some compromised area, maybe the 2 or 3 millimeter very narrow ridge with us, or some compromised situation area. With the big GBR procedures are necessary part, non-contained defect. How can you solve this situation? Just only the bone level? Bone level is able to overcome this situation? I'm not think so. I don't think so. Because of the tough situations, we have to change the mind. Compare each other. The smallest diameter of bone level, the Dentium company, which size? 3.6 of 3.6 supraline and the bright bone level, and aniline 3.2 diameter, right? Very thin walls, when we connect with the abutment, very thin walls layers remained. So weak, sometimes so weak. So the out of axial wall or some occlusal overloading or some the position is not good situations, we have to worry about fixture tearing or fixture fracture, right? However, in this kind of case, we can, if we can choose NTI soft tissue level implant, the make me free. This NTI make me free from worried about the fixture tearing or some the fractures, right? It means even though we can choose 3.5 or 3.0, the smallest diameter, the platform is 3.8. This smallest diameter, even though the smallest diameter, the stronger than the one size bigger the bone level fixture. 3.0 same as 3.6. Okay, 3.5 tissue level equal the 4.0 bone level, right? The same, the strength. It means choice of NTI tissue level means make me free, right? So I strongly suggest for you, when you have restricted and tough situations, narrowed reach or the non-contained defect and tough situation, you can use this bright tissue level implant instead of bone level. Okay, I strongly suggest to you. Okay, thank you for a long time for watching me, for watching this live surgery, and thank you for having me. And we will have a next live surgery 2002 this year, the August 19th. August 19th, Korea time, 7 o'clock. So we will see again this time. And actually in Korean time, the show 시즌 1 빠른 15분 정. So I think Beijing the 시즌 7된 20분 정. So for a long time, thank you for watching me once again, and see you next time. 부전 부산. Bye.